topic itself, you can figure out what we're going to talk today. Is about difficulty in breeding a newborn. Newborn means that the child just been, the baby that just been born. When they come up to you, they come with respiratory distress. So uh, the keyword here is respiratory distress and newborn. Okay, first of all, go for the cause of respiratory distress. I mean, causes of respiratory distress. So it can be due to many system. So when talking about newborn respiratory distress, you look for that and you to find out the causes. So what the causes? Causes can be many causes. You have to look into respiratory system, cardiovascular system, central nervous system, musculoskeletal system, metabolic system. All these can cause respiratory distress. But I'm going to focus more on respiratory system because that is the main thing that being reason why the child be admitted. Because respiratory system. But we're going to touch a little bit about the other system. So looking back, you see the causes of respiratory distress in newborn can be many. Can be involved respiratory system, which involve airway obstruction, disorder of chest wall and diaphragm, malformation of the intestinal and lung parenchyma, Ehrlich syndromes, and primary parenchyma vascular disease. Okay, there is a possible causes. Later we go case by case according to the community. So can be obstruction, can be stenosis, paralobin, vocal cord paralysis, coronary atresia, hemangioma. Chest wall can be so many cause of chest wall abnormality, shape. That I can't remember the name. Thanos something. Very abnormal shape. The other one congenital deformity hernia. And then malformation of the mediastinal line parenchyma, congenital cystic, so all very rare. All these are very rare. And then Ehrlich syndrome, pneumothorax, can cell is you can see, we do see once a while. And then lung parenchyma, this one common. Junction tachypnea of the newborn, meconium, then LDS, Hallerman disease, very common. The other group is the cardiac disease. Cardiac disease can be due to cyanotic or acyanotic. Mainly, there are many causes of acyanotic, mainly but result in one severe cyanosis. Second is heart failure. Either one can result in respiratory distress. There are good neurological disorder, including birth trauma, ischemic heart disease, ischemic child asphyxia, intraventricular hemorrhage, and the rest are quite rare. And the other group is quite common, but they are transient most of the time. Sepsis, anemia, hypernatremia, or the electrolyte imbalance. And then this is quite common in the unit, in the newborn. So the most important is respiratory sign. The most important, the respiratory signs. And you can divide as mild, moderate, and severe. Mild, you can come with tachypnea and tachycardia only. Moderate, they can have subcostal recession, nasal flare. Severe can be sinus, grunting, drowsy, and comatose. So depends on the it can be mild. So when patient baby come out, you have to decide the patient is mild, moderate, or severe. And these signs will help you to decide. Uh, the baby which come out is mild respiratory distress, moderate respiratory distress, severe respiratory distress, because you need to know to decide the level of management. Mild, probably you just get oxygen only. Moderate, probably you give some oxygen, or then probably you give some bed or CPAP or BiPAP. Severe, maybe you have no choice but to intubate. So the level, because very important, there's two. When baby come out, you have to decide the level of severity to decide the level of management. The other sign which is non-specific, such as poor intolerant feeding, inactive, poor perfusion, hemodynamically unstable, stridor, weak, listless, or temperature instability. All this is non-specific compared to this one, which is rather quite specific. And then the treatment-wise, always ABC, airway breathing and circulations, secure the airway first, do the suctions, position the baby properly, give back a mask and intubate. And then look at the breathing. Breathing is the breathing has to be adequate, good enough. Then after that, you go to blood pressure and perfusion, and then treatment. Then only then you decide to treat the specific causes. What the cause of the respiratory distress. So this is you do an RP usually, unilateral resuscitation. And then a little bit about the anatomy. As you can see here, the respiratory system start with nasal cavity, pharynx, epiglottis, larynx, trachea, and then go down to the left lung, right lung, pleural space, and diaphragm. Right? That is the thing. And then see the bronchus, alveolar sac. This is quite deep. This is lower airway. This upper airway is a lower airway. And then after that, it goes down to the bronchioles. Respiratory bronchioles, uh, AV broncho, respiratory bronchioles, then alveolar sacs and alveoli. This is how the respiratory system. The other thing is the muscles and then the diaphragms, basically. And then the progress, a little bit about the development of the respiratory system in intrauterine, something that we have to understand. Probably you don't need to memorize that to understand, so that easy to understand pathology. So start with the respiratory system development, start with embryonic phase, first 3 to 5 weeks, pseudoglandular phase 6 weeks to 16 weeks, canalicular phase 17 to first trimester, second trimester, third trimester. And then the alveolar phase start at the 24-week. Before that, very little alveoli, so difficult for them to survive with the alveoli if they come out from intrauterine. So 24 weeks where the alveoli start to develop. And the alveoli start to develop and new alveoli start to come out until the age of 8 years. After that, it stop. It will be permanent, the numbers, but the size and diameter continue during the adulthood until when you stop your the length the length or the tinggi you stop, and then that is where the respiratory system stop to develop. Okay. So little bit embryonic, pseudoglandular, canalicular, circular, and during this time the surfactants start to come. So the alveolar phase here, and then surfactants start to come. Very important. Surfactant is a very important chemical phospholipid that needed for proper function of the respiratory system, so the alveoli, and then that's why you're born. The baby being born normally, but sometimes because of certain things or event, they can be born earlier. But then you see beyond 24 weeks and below, it's big difficult to survive. First, there's no surfactant, no alveoli, inadequate, and second, no surfactant. So there the phase bronchi, bronchioles, terminal bronchioles, respiratory bronchioles, alveolar ducts, and alveolar sacs, alveolar ducts and sacs. And then conducting phase, and then the respiratory transitional respiratory zone. And then where the first trimester, formation of major airway gonogenesis, and then differentiation of the respiratory system to become the functional organ. So respiratory system, you start with the first one, the common that you saw in the clinic, in the ward, in the newborn, the causes in newborn, when you saw the patient, one is the start. I start with respiratory system first. Respiratory distress syndrome. Respiratory distress syndrome started with is due to surfactant deficiency. As you can see the slide earlier, the surfactant start to be detected in the alveoli at the age of 26 weeks. So surfactant is a phospholipid. The function to prevent the airway to collapse. The risks of surfactant deficiency are prematurity, male sex, perinatal asphyxia, maternal diabetes, antepartum hemorrhage, and serial section. And then diagnosis by history. The management more of respiratory support. You give the support until the lung properly matured. And then surfactant replacement, the main if needed. And then the other one is fluid, electrolyte, acid-base balance. And then you can see the function surfactant. What happens is surfactant deficiency. The function surfactant is to one, increase pulmonary compliance. We're reducing effort to expand the lung and reduce tendency for alveoli to collapse. The function because there is the function surfactant. So where surfactant work? Surfactant work here. Interface between the air and the fluid. This surfactant work here. Surfactant. So surfactant here, it maintains the tension membrane, tension surface tension, preventing the alveoli to collapse. So that there will exchange of the gas occur here. And then this is what happen if the nose surfactant the lung become collapse. It looks like liver. So this one, very non-functional lung, and lung definitely cannot function to do the gas exchange. And this very severe type 3 RDS. You can see no air, only just air bronchogram only, nothing else. Very whitish lung, solid whitish lung. And then this kind of case you need to support the ventilator, and then at the same time you give the artificial surfactant. It's Saventa, organic or non-organic, artificial. Saventa or this one, Saventa is one from the Saventa is not Saventa is artificial, made in the lab. The other one, congenital pneumonia. By this one you know already what it means. Pneumonia means infection. Congenital means that they get it inside intrauterine or during delivery. Main organism is group B strep, commonest, very common. The other one, Listeria, Klebsiella. The risk is if maternal fever, maternal having infection such as UTI, chorioamnionitis, premature rupture membrane, prematurity, colonization of the birth canal with group B strep. Treatment is, of course, antibiotics. And then the transmission can come from hematogenous, ascending, or aspiration. So the sign and symptom can be elevated respiratory rate, retraction of the chest, grunting, nasal flaring, increased mucus or other fluid substance in the airway, unstable body temperature, poor feeding, abdominal distension, jaundice at birth, glucose intolerance, and hypoperfusion, oliguria, and cyanosis at the center as strong. And you see the chorioamnionitis, inflammation of the chorion, result in the transmission of uh, the transmission of the infectious materials into the result in infected child. And then the other one is for birth canal. Coming birth canal contaminated, and the other one is the hematogenous. And the X-ray bit difference. You can see the X-ray fluffy, bit fluffy the X-ray. Doesn't look bit fluffy the X-ray. Bit difference. That's solid. It's still consolidation, but it's soft consolidation. The other one, transient tachypnea neonate, which is fairly common now. Usually, you can occur 1 to 2% of children. Transient tachypnea neonate. Neonatal, TTN, shortly kita panggil. And then this usually occur in preterm, large preterm, and term. Large preterm, it doesn't occur much in the prematurity. The pathophysiology is that when you are intrauterine, when the fetal intrauterine, the lung contain fluid only, not air. So when the child come out into the come out intrauterine to extrauterine, I mean that environment as what we are now, the lung have to be cleared from the fluid. But certain patient, children, baby, a newborn, they takes time to fluid from the lung to be cleared. As a result, there are residual of fluid inside the lung, and this result in the lung become wet. And the future is a child tachypnea, grunting, with cyanosis, and then they because the lung cannot function normally to do the gas exchange, but it rarely persists beyond 48 hours. By that time, the body will absorb all the residual fluids in the lung, and the lung will be clear. The main risk factor is cesarean section. Many of the child, because cesarean section are too fast, that they are unable to clear the lung fluid fast enough, and then they need time. When they come out, they need time to lung to be cleared properly. This is the X-ray. The X-ray, look the chest X-ray, you find out the air in the fissure. Air in the fissure show that there is a fluid, lung is wet, and called TTN. Lung is wet. Meconium aspiration is another common, not very common now, but is still fairly common. The what happened is that kadang kita dalam Melayu tu panggil, oh budak tu berak dalam perut, dalam kandungan. Tapi what it means is that the meconium being secreted out through the anus, which contain of fetal genital secretion, epithelial cell and hair, and then this meconium, for certain reason, when they are floating inside the intrauterine, it been aspirated into the lung, causing the obstruction and pneumonitis. The risk factor is a postern asphyxia, mitral asphyxia, and also postern. I mean, they will be born after a certain age, after the term 38 weeks. Future is meconium liquor. The liquor is meconium stain, and then there is reason of SP distress. So you must have two evidence. One, the liquor have to be meconium stain, and then there are respiratory distress. Treatment is more of prevention, and preventing the child to pass the motion inside to intrauterine, or the other one is when there are meconium liquor, to prevent the meconium being aspirated into the lung during delivery. And you see this meconium, this meconium. This is one of the very severe type meconium. This one very thick type, and meconium. Imaging this one goes into the lung. So you can imagine the damage it will do to the lung, obstruction, and also inflammation to the lung, pneumonitis. The pathophysiology quite complex, not to discuss about that. And then the X-ray different from the other X-ray. You can see the lung hyperinflated, and the soft fluffy show that the meconium is aspirated. But the airway, the lung is more rather hyperinflated. The other cause is pneumothorax, pleural effusion, pulmonary hemorrhage, and then congenital multi-cells, hypoplasia, sequestration, congenital diaphragmatic hernia. This one siapa boleh teka? Siapa boleh teka this one?
Congenital diaphragmatic hernia.
You can notice this is a post-mortem of the born, the newborn that born that on been born, stillborn call it. You can see the right side of the lung, the left lung toxic cavity. There is a organ of the abdomen, intestinal, and then all the intestinal. And you see the lung here being compressed, and then the heart being pushed to the right side, and the lung is to be compressed. This is our diaphragmatic history. You can do that. where there is the diagnosis only by X-ray is adequate already. Can tell you that there is a organ of the abdomen inside the left side of thorax cavity, and it's mainly because of the deformity, being deference not complete, being developed. There is a hole here result in the abdominal organ being pushed into the thoracic cavity. Here, that's more diagram. This is a very rare one. Sometimes the child will come until the age of 6, 7 years old. They come with symptom of strangulation. We have case where big child, sometimes very 7, 8 years old only they come. Ini, anybody? Siapa nak teka?
Is it left pneumothorax?
This, yes, this is a left pneumothorax. Very big air inside the pleural cavity. And then you can see the heart being pushed to the right side, the lung here compressed. Treatment was there are those with because of ventilator induced, the one dose spontaneous. Then the treatment is just put chest tube or cucuk saja this one, and then the air will come out. Air will come out, and then the child will recover. Ini, siapa nak try? Kawan sama je.
Is it lung emphysema? Lung emphysema.
How you know lung emphysema?
Because there is a over at the right side there is a like
Where is it?
there is a like consolidation over the right lung.
Mana consolidation?
At the right
You see
middle.
the X-ray first. You see there is the heart being pushed to the left side, is it? And then you can see the recency tak sama. This a bit whitish, the more but this quite dark, this more whitish. And this nice margin here. CT scan show that there is a this CT scan corona. Can you see that is normal lung? And there is a something here. So there is a lateral something here, and then something here. There is called congenital lung emphysema, CLE. Ini ini hmm? Anybody? Nampak apa ni? The color is bit different here, is it? The consistency not similar to the heart, is it? Heart is a bit more whitish compared to this one, Yeah, this a mesh here, is it? The mesh compress the airway here, and also compress the lung on the left side of the lung and the airway here. So this is called bronchogenic cyst. Cyst is not a solid mass. That is solid mass you see can hear white. Dia solid Bronchogenesis. Ini anybody? Anybody?
Bilateral lung hypoplasia.
You can see this is the chest thoracic wall cavity. But then the diaphragm is here, and the lung very small. This is the lung hypoplasia. This is how the lung looks like, very small. And this one is not viable to live. So no point of trying doing something, because if you ventilate, so you cannot able to ventilate because there's no lung, not inadequate lung per se. This is airway abnormality. Example, airway stenosis, laryngotracheomalacia. Airway become very stenosis, it means there's block to the airway. The malacia means that the airway become very soft, easily collapse. The one is tracheoesophageal fistula, I mean the fistula between the airway and then the airway and then the esophageal fistula. All this result in difficulty in breathing in children, in the babies. The other group is a heart disease. It be congenital heart disease, cardiac failure, cardiomyopathy, system fetal circulation, cardiac. All this cardiac abnormality can cause newborn distress. And then it can be due to lung fluid, result in fluid lung become very stiff, increase work breathing to maintain the cardiac output. I mean, in certain case, especially cardiac failure, result in metabolic respiratory acidosis very high, with high PCO2, congenital heart disease, this cyanotic heart disease. They are pulmonary hypertension, those with pulmonary hypertension, persistent pulmonary hypertension, because you know that intrauterine your pulmonary system are in high pressure, higher than systemic, and persistent extrauterine result in persistent pulmonary hypertension, and then if physiologically unviable to live, the child result in the respiratory distress. The good spinal muscular CNS and the spine, anything the CNS spine can result in the respiratory distress in the child. Then especially, but not very common, except that if the child develop, let's say, intracranial hemorrhage. But then, though that one is not very common in unit. Example, give spinal muscular atrophy (SME) syndrome, where there is a destruction of the abnormality of the spinal cord, the anterior spinal cord, then result in the atrophy of the muscle. There are many groups, various groups. So go back earlier, respiratory causes, cardiac causes, and then neurological causes and other causes. All that can cause a respiratory distress. I will little bit emphasize here, little bit about sepsis, anemia, polycythemia, hypothermia. Hypothermia, if you baby come out very premature, you didn't mean they have easily loss of temperature, the heat result in hypothermia, then they can also develop respiratory distress, and then electrolyte immobility, and the one hypoglycemia. Hypoglycemia can come with anything, sepsis like feet, and also respiratory distress. So treatment wise, assess the child. When the child come, the baby come out, you must able to assess. You will know that this is normal, this is not normal, and not normal. The child has respiratory distress. You have to decide, is it mild, moderate, and severe, and then you have to do your immediate management for the respiratory distress, including the ventilation support. Remember your airway breathing circulation, and then treat the main cause after that. Hypoglycemia, you give fluid. Sepsis, you give antibiotic. RDS, disinfectant and ventilate the child. Or meconium, you suction, clear the airway, and so on. Depend on the causes. Okay, any question? No. CPAN, most of the time, this CPAN good enough already. Okay, anything else? Any other questions? Tak ada? As usual, tak ada question kan? You all know everything. Okay. So next week, apa tu? The first group dengan I pukul 4 ya. If there no changes in ni will be Monday 4 o'clock. Okay.
Okay.
Okay, settle ha. Okay. Siapa?
Thank you,
Nurul Putri?
Doctor.
Nurul Putri siapa? Nurul Putri ni?
Saya,
Nurul Putri.
Doktor.
Ya. Nurul Putri nama Nurul Cahaya. Nurul Cahaya kan? No, Nurul Putri. Dia nama orang Melayu. Okey lah. Jumpa you all nanti. Najwa. Siapa lagi? Najwa. Aman saya kenal lah. Aman. Syamimi. Taufik. Siapa lagi tengok? Nama. Dah doktor apa tu? Doktor tu dah. Siapa tu? I'll read the brief you all.
Dah, Doktor.
Dah. So you all did this your last posting kan? Before the exam kan?
Yep.
Yeah. Okay you all. Okay tak okay?
So far so good sekarang.
Siapa group leader?
Saya.
Ya. Siapa group nama group leader?
Atira.
Ha?
Atira.
Atira.
Mm-mm.
Saya muka tak lupa. Sekejap. Mak Wakilah Aiman Ifat Farah Amirah. Yang bawah tak nama Tak apalah, nantilah. Okeylah, good luck lah for you all. Okay, so please take peluang sini, belajar elok. Okay.
Alright, thank you, Doktor.
Thank you, Doctor.
Okay.
Thank you, Doctor.
Thank you, Doktor.
Thank you, Doctor.